Hello everyone, and on behalf of WorkUP Queensland, I would like to welcome you to Strengthening Queensland's Response to Substance Use Coercion. I'd like to begin today by acknowledging that this forum is being broadcast from unceded Jaggera and Turrbal lands and pay my respects to elders past and present. Wherever we are joining from today, we are on unceded Aboriginal and Torres Strait Islander land, and I'd also like to acknowledge and pay respect to Aboriginal and Torres Strait Islander people participating in this session. It is a pleasure to have you all join us today. Spark webinars are an opportunity to connect practitioners with current research, promoting knowledge sharing across the sector, and creating a space for reflecting, thinking, and talking about practice. Today we are coming together at an important moment as we adjust to a new reality in which coercive control is now a criminal offence here in Queensland. The lens is turning to how our systems respond, including how substance use coercion is increasingly being recognised as part of that abuse. Over the next 90 minutes, we'll unpack how substance use and coercive control intersect, explore what this means for practice and cross-sector collaboration, and share some tangible steps towards building safer, more responsive services for people experiencing substance use coercion. I'd like to start by introducing our panel of experts. First, we have Cathy Humphries, Honorary Professor of Social Work at University of Melbourne, a distinguished researcher whose work at the intersections of domestic and family violence, substance use and child safety have shaped policy and practice. Next is Margaret Cortez, a social worker and researcher at the University of Melbourne, with nearly 30 years' experience in DFE, child and family welfare, and out-of-home care. Her work focuses particularly on cross-sector collaborative service responses where domestic violence and substance use co-occur. And we welcome Van Kalali, an early career researcher at the University of Melbourne, whose PhD examines how DFE and AOD systems can work together more effectively. Drawing on her background as an AOD clinician supporting families with complex needs, Van brings a strong focus on systems change, policy, and workforce capability. We're also joined by Monique Newman, General Manager, Child and Youth Family Services at Kids First Australia. With more than 20 years' experience, Monique leads major state-funded initiatives and systems integration projects. And joining these four interstate experts are two local distinguished speakers. Paula Angustine, Lead Training Developer for the PHN Local Link project, led by Micah Projects, bringing practice, training and workforce development expertise at the intersection of DFE and AOD practice. And Rebecca Lane, CEO of the Queensland Network of Alcohol and Other Drug Agencies, representing the AOD sector in Queensland and bringing a strategic statewide lens to the conversation. Together, our panel brings a mix of rigorous research, practice, training and sector leadership, which means we're well placed to explore how to navigate the complexity of substance use coercion and working collaboratively across sectors. Welcome, panellists. Before we step into today's discussion, we're going to share a short excerpt from the latest episode of the CVIL Conversations podcast. In this interview, we hear from researchers and practitioners discussing what we know and how we respond to substance use coercion in research and practice.
when we talk about substance use coercion, it doesn't apply to all families.
No.
We recognise that substance use exists on a spectrum.
Absolutely.
Anything from non-problematic, enjoyable substance use to, the other end of the spectrum. But what we're talking about here when it comes to substance use coercion is thinking through how is a person who's using violence exploiting the victim survivor's substance use to extend their own power and control.
Absolutely.
So the example I could think of is, if a woman is choosing to use illicit substances on a night out, then there's no harm to self or others in this context. That's fine. But when she returns home, if a family member is taking that substance use as a way to undermine her, to call her a bad mother, to, use that as evidence to child protection and so on, I think that's really a clear sign to me that substance use coercion is occurring. So the focus here with this concept is really thinking through how's the person who's using violence weaponizing a victim survivor's substance use.
In the family services sector, predominantly it's mums that are referred through, and so they are the primary client with their children. And so how that sort of plays out then is that they are seen as responsible in terms of the parenting role, and when it comes to substance use, and if we don't have a really good understanding of what that substance use looks like, what the real impact is on the children, we go in with a lens of any substance is bad and any substance has a negative impact on parenting and on the children. And so then what that looks like is that we will go in with really high expectations of mum to address her substance use. It's quite harsh, can be quite harsh, and the children are kind of invisible there, even though it's through a lens of we need to protect the children. It really elevates for women, for mums, the concern around risk for their children. There's a lot of, stigma associated with substance use. There's also stigma associated with mental health challenges. And when we think about the expectations on mums as opposed to the expectations on dads, they're quite disproportionate. And so when we have mothers who are experiencing substance use challenges, even including prescription substances, the expectations and the focus, I guess, on them to keep their children safe is so much more pronounced than the expectations on the person using violence. And often that person is using substance use coercion in that relationship. We often miscalculate the risk. So we focus the risk on what mum's doing because we haven't heard her or assessed her with genuine care, curiosity or capability. And so, as Monique was saying, we are meeting her with a moral view and kind of the moral paradigm of substance use rather than exploring what does substance use mean for her? How was she introduced to substances? Getting an understanding and actually doing a psychosocial assessment, supporting her being where she's at, because we're doing women a disservice. We're actually actively doing a disservice to mothers and assessing her behaviour as the larger risk and missing what's actually going on behind the scenes. I guess when mothers disclose substance use as well, they're coming to us because they want to share their concerns, they want to share their risk, but then alongside with the stigma, that instigates a statutory response. So it can actually make things worse for the family. And what we do see is women turned away from services because they are using substances. And so when someone's coming to us asking for help, how do we as a service system, irrespective of what our specialisation is, meet that client where they're at and provide tailored support to what they need rather than turning them away because of a moral standpoint or a lack in our own capability. Held mum up to a different level and a higher standard, and also
stigmatised her for using substances and blamed her for something that is not of her doing.
And increased his power.
We really need to think about and look at how we're viewing substance use and how we're viewing mums and women in the context of substance use, thinking through, a harm minimisation lens, but also like really trying to understand, well, what is the substance use about? When is she using those substances? What is the impact of this? What are the substances? Because there are varying, substances that mums might be engaging in, and we need to understand so much about the context and the drivers of that substance use so that we can really get into working with her around whatever it is that she's needing that support with.
You can do family-focused, child-focused harm reduction work within the alcohol and other drug space. It's not overly complex. So I think it if nothing else, for the kind of practitioners that are starting to engage in this work, it is exploring what does harm reduction mean and what do those conversations look like with victim survivors, which can absolutely navigate substance use coercion as well. We can hold this complexity. It's not beyond us. We can definitely do it. So it's really important for us to upskill, but also to be advocating for the change that we want to see within our sector.
From the research we've seen, any integrated programs that address both family violence and drug and alcohol simply isn't being sustained beyond the pilot phase.
I actually think we're not clear yet about the models that are most effective in this space because we haven't had the chance to do substantial evaluation in this area. If something only gets to pilot phase, like say Cody, you've only got very small numbers. Like we've had a go, but actually the numbers are too small to really say this is a model that works. And when you looked internationally, there were 9 programs, weren't there, that were peer reviewed, of which by the end of your scoping review, half of them had already finished and weren't sustained. So that I think we're not clear either for victim survivors or for working with the person using violence or for children about what are the best models. Should it be that where you've got working with, men's behaviour change, you need an alcohol and other drug specialist in that space, or should they be jointly facilitated? Should it be secondary consultation? Should it be that you just support the collaboration? There are different models that we could use in this space, but we haven't had the opportunity to really look at the data or to evaluate to say this is the model that potentially works the best. It seems to me that one of the biggest gaps in the whole public health approach, which is looking at primary prevention, secondary prevention and tertiary prevention, so looking at how do you prevent it from starting, how do you support and intervene where you've got children and young people at risk, and how do you respond or do the healing and recovery once it's all happened. The biggest gap is in that secondary prevention. We're not getting in early enough. Like every report you read says we need to intervene earlier. Well, let's intervene earlier, but where have we got the least resources coming? No resources in this saying, actually, let's not wait till we've got to the crisis, which is the tertiary prevention. We know that children who are living with domestic violence and substance use are at risk in all sorts of ways, both right at the moment but into the future, in terms of their health, their well-being and intergenerational abuse.
Like we've had, the Royal Commission into Family Violence and significant reform, I would like to see something similar within the alcohol and other drug space, the substance use space, because with the authorisation of the recommendations, we have been able to see significant change, that this is part of all of our work. Family violence has become part of everybody's work and responsibility. I would love to see that shift within the alcohol and other drug space, because when we think about substance use, we always have the kind of stereotypes. We're missing so much if we just stick to the stereotype and if we're not working in an integrated way. So I'd love to see development in capability within alcohol and other drug space, within substance use coercion, and understanding that, and for the systems and the sectors to work in an integrated manner. I think that is the key. We've spoken about staying in our lanes and what that looks like, and, you know, it can be sort of almost a competitive environment. How do we move away from the competition and actually focus on developing a system that is tailored and targeted to what the community need?
That was a short teaser from the Seaville Conversations podcast. The full episode was released today and features a longer and engaging discussion with our speakers. We will pop the link in the chat for you to explore. Now to our live panel. Can you expand on the definition of substance use coercion? What behaviours are we talking about? What dynamics are at play? And what might practitioners see and hear in their clients?
Thank you for that question. So before I provide some of the examples or dynamics that might manifest within families experiencing substance use coercion, I would like to state that this concept exists on a continuum of practices, and this is simply one way, a nuanced way, to understand the intersection between drug and alcohol and family violence. It's also important, I think, to recognise that it doesn't exist in isolation, but intersects with other forms of domestic and family violence and coercive controlling behaviours, including sexual violence, systems abuse, and other tactics of control. I guess some of the dynamics or examples that practitioners might hear about coming from a victim survivor perspective is that victim survivors who use substances may state that their substance use is actually worsened by a family member. So that family member might try to encourage that victim survivor to use more, or that the person using violence may become angry when the victim survivor declines substances. So in this example, we see the victim survivor using and maintaining that use to reduce the harm to themselves and their children. In addition, we might see victim survivors who state that people using violence will interfere with their recovery, and also, victim survivors' withdrawal symptoms might be exploited by a person using violence until they follow what the person using violence says. So overall, there's many other dynamics that we can talk about, but it's really about the victim survivor reporting that they feel their agency and autonomy around substance use and their recovery is being hindered due to the actions of another family member. I would say it's also equally important to think about how substance use coercion applies to a person using violence and also substances as well. So a person using violence might excuse their violence due to intoxication or states of withdrawal, and they'll continue to repeat these assaults on family members. Likewise, a person using violence and substances might deny any sort of responsibility or accountability. And what we see in these dynamics is that the person using violence will try to structure the family dynamics to maintain their substance use lifestyle despite the consequences it might have on other family members.
So basically, at its heart, substance use coercion is about what are the tactics of violence and abuse used by the person using violence, both about themselves and then the way in which they use any substance use from the victim survivor to increase their tactics of violence and abuse.
We sometimes hear that drug and alcohol use causes domestic and family violence. How would you respond to that?
There are a few things that come to mind when I hear that. And firstly, what I would really consider in that space is the word cause. It really isolates, and I think that's might be the heart to what we'll be talking about later on, is it isolates the alcohol and drug use from the domestic family violence, making them two separate issues. Another thing that I would really pose to that question and ask anyone who might hold that belief is, what are the underlying beliefs and assumption that someone who uses violence, and how does that present on a larger scale. So what I would really like someone to think about if they have that belief is, would this substance coercion exist in isolation? So if you took away the whether that's the person using the violence, using the substance, or the victim survivor using the substance, would there still be violence in the relationship? What we might find over time is that if there is substance use involved, that maybe the violence will increase in some regard, or it might not. But at a core, what causes domestic and family violence isn't substance use. We're looking at whether that's individual beliefs and patterns or the system's beliefs and patterns is really where domestic family violence comes from. And it's in the name. It's in the name of gendered violence as well. Like, there is an underlying reason, and it's not substance abuse.
Yeah, I think it's really important to remember that a lot of people use drugs and use alcohol, and almost none of them are violent. So there's definitely, this is the intersecting piece. So the thing that comes first is the use of violence, and then if substance use is then connected to the use of violence, then that's where we get the really awful outcomes. Certainly our members talk to us about having a degree of confidence and capability these days about working with victim survivors and understanding the basics of safety planning, how to identify when someone is in a relationship that is has the features of coercive control, or has the features of family and domestic violence, even where they might not be connecting those dots for themselves just yet. But where they really struggle is in, 50% of our client base are men aged 18 to 44, and all of them have emotional regulation problems sufficient that they use substances to help them manage their mood. So the lack of clarity around the connection between those two things and the use of violence, because it's not a straight line there either. And then if you are in a situation where you think you are working with someone who's using violence, you're trying to help them with their substance use, like, how do I resist the urge to collude with them? And how do I make sure that my actions don't make it worse for their current partner or their family members that are around them? Are the things that we hear a lot about from our members.
Well, I think that it's very easy to collude because there are social excuses that are made at a structure. We really do have a culture that excuses people when there's violence. It's like when there's drug and alcohol. It's like, at least for men, it's like an accountability-free zone. And we do particularly stigmatise women who use substances, and particularly alcohol, so that there are these social interplays that affect the way in which people tend to work in this area, or how either victim survivors or the person using violence are seen.
And I think this really plays out within the systems within which we work. So thinking about, and it is referenced within the longer version of the podcast, but an example where substance use coercion really played out that we were aware of and intersected with a family at Kids First was a father who was referred into the Caring Dads program, and we came to be aware that he was really engaging in substance use coercion and was engaging in systems abuse as a part of that. And the situation was that the mother, and there were 3 children, the mother had some mental health challenges. She was medicated for those mental health challenges, and the father was identified as the safe person to enact the safety plan and to administer her medication. And so he used that power and control to essentially overdose mum. And then that played out in that she was then hospitalised. The children were removed from her primary care. He was identified as the safe person, and yet he was the exact person that was unsafe. And so the system played into that coercive control, and the system colluded with him.
Margaret, you are co-leading a national consultation exploring intersectoral practice between AOD and DFE services. What are you hoping to learn from this project?
Thanks. Yes, Kathy Van and I are working on a project called the PIPSI project, which stands for Prioritising Intersectoral Practice Strategies and Innovations. And I got that right, didn't I? And we've been interviewing key stakeholders and experts across the country this year because the main focus of the PIPSI project is to support frontline practice. So the practitioners who are working with the families who are living with both these issues in whatever form that takes, substance use coercion being part of that. So we're looking for, what will support workers to do this, to do a better service response. We've been asking people about what practice models work, and I don't think we're there yet in terms of, there's a number of practice models that might work, integrated care, coordinated care, specialist advisors, so family violence specialists informing alcohol and drug services and vice versa, alcohol and drugs specialists informing domestic violence practitioners. So there's a number of different options that we're continuing to explore. So that's one of the things. The other thing that's really come out of these consultations is mapping all the work that's actually already happening. And it's a lot more than even 3 years ago. As Kathy says, it's 1,000 flowers blooming. A lot of workforce surveys, including Beck, what CUNADA's been doing. So mapping that so that people can see and share ideas about what's actually happening at small scale or larger scale. And then the other point I wanted to make was we're facilitating a strategic policy group with experts and stakeholders, again, from all states in Australia. And it's a social learning group to really drive the practice and policy agenda, work out what we need to do and where we can create a bit of leverage to move things on.
Kathy, why do you think this project is so important?
I think that we are at quite a crossroads at the moment where a few years ago, when we first ran our first project in this area, we began with a lot of the senior managers that we're bringing together in the policy, what we call the policy stakeholder group, that a lot of those senior managers were very afraid to speak. They said, look, if we talk in this space, we're really afraid that we're going to say the wrong thing and that we'll have reputational damage to ourselves and our organisation. So we had to spend a lot of time in the beginning setting up the ground rules about how do we make this a safe space. And we're talking CEOs, we're talking the leads, senior managers, we're talking about our peak body leads, CEOs, board members. So senior people saying we're too afraid to speak. I think we're moving past that space now, and now there's more work able to happen. And what we're seeing is that, in fact, this mapping that Van's done showed all sorts of things happening across Australia. And so this time we've got representation from across Australia. We've got a lot of the peaks from either the substance use area or from the either the men's domestic violence sector or the women's, the survivor sector. And so there's an opportunity here to really progress the agenda with thinking about what can we do over the next 3 years to see how we can move practice. Because we're not actually necessarily interested in this level up high. We're interested in how do you work with the tactics of violence and abuse in our practice areas? What do frontline workers need that would make a difference for them? I don't know whether Van wants to speak a little bit more about the mapping, because she was right into sort of drowning in the data from these, from all our interviews and trying to map and make sense of it.
Thank you, Kathy. Maybe I'll just talk briefly on that topic because Kathy and Margaret have really covered it quite well. But as a part of the mapping, we consulted 33 professionals across different states and territories to identify what are the current responses that are happening in response to the intersection of drug and alcohol and family violence. Essentially, what seems to have happened over the past, 5 years since we've been doing this sort of work is that the conversation around drug and alcohol and family violence is becoming a lot more normalized. It's becoming a part of public discourse, and there's a lot of attention and awareness on this issue. And it's not surprising because frontline practitioners have been grappling with this complexity for quite a number of decades now. I mean, Kathy, you started working on this in early 2000s? Yeah. So what we're finding is that a lot of peak bodies, senior policy actors and even governments are starting initiatives or have already well underway developed initiatives to respond to this intersection. But the question is around how do we sustain these approaches to ensure that it constantly is refined and developed, because it can't just be a 3-year initiative or pilot program or set of training that is enforced, but has to be continuously trying to catch up with the new ways that drug and alcohol can become a tactic of abuse and violence. So very interesting findings that will be evolving over the next couple of years.
Were there any other early insights or surprising findings from the work that you've done already?
I would say from the initiatives of the mapping has shown that we're getting better at being able to identify substance use coercion or even just the intersection of drug and alcohol and family violence, but it's not clear yet how practitioners should be responding when it comes to working with either the person using violence and substances or the victim survivor using substances. So that is the next step.
And I think the other thing is that these conversations we're having are with people who are interested in this topic. So in some ways we're talking with the people who are the experts in the country. We're still, and I think some of the workforce surveys will show, my sense is that there's a lot of practitioners trying to do their best on the ground for the families they work with, where we've still got a long way to go to help them understand how all these issues intersect. And Monique's example was a great example of how it's not just these two issues. You bring in mental health and another form of coercion, and there's a whole range of things, isn't there?
Monique, you have been working collaboratively with Odyssey House at Kids First. Can you share any insights from the work that you've been doing? Any insights from the collaboration? Any advice?
Kids First and Odyssey House partnered a number of years ago in looking at how we could deliver a Caring Dads program to a cohort of men using violence, who are dads, obviously, where substance use was also intersecting there. And so I think some of the insights that I could probably share are around, firstly, just relationships are key. So if we're working across sectors or across organisations, really working on those relationships is so important, and finding what I guess the synergies are and what the shared goal is. So for us, it was around the safety of children and working with dads and whole of family to affect the safety of children. So finding that helped us then to work out all the other bits, which can be quite messy, particularly if we're working across sectors where we have different funding models, where we have different, KPIs for want of a better terminology. If we have, a bit of a shared goal, then we can work out some of those tricky bits. What we also found in this work, where we had some family violence specialists in terms of people working with men who use violence, and then we had the AOD specialists, there was a great opportunity and a really great outcome in terms of workforce capacity building. So there was a real shared knowledge across both of those different workforces. There was capacity building that occurred that then led to, for Kids First, the caring dads, facilitators, really having a greater understanding of the complexities of substance use, really starting to understand a bit of that substance use coercion, and how harm minimisation can then be supported within that PUV space as well. So those are a couple of learnings that we came away with. I think what is a barrier continues to be that there are, I guess, in terms of community understanding, but also I guess it's that socialisation of substance use and what that means. So for families, I think where we have victim survivors, mums who may be using substances, where we're not digging down and understanding what that's about, and we're coming in with our judgment about, kids are not safe because mum's using substances, those sorts of things. That's a real challenge. And that's something that within the workforce, we really need to socialise around substance use and what it actually means and how substance use coercion really plays into then a victim survivor's experience and the children's experience of that as well.
What is a harm minimisation approach and how does it compare to other approaches?
So a harm minimisation approach is Australia's approach to managing illicit drugs. So it's essentially a three-pillared approach looking at demand reduction, supply reduction and harm reduction. And so in this instance, I think the key kind of thing is harm reduction. So instead of starting from a position of you should stop that and everything else will become magically okay, you start from a position of understanding how the substance use is, what it's doing for the person who's using drugs. So for mum, in this instance, it could be that her life is really precarious and stressful, and in holding all of the things together, she uses, say, cannabis, for instance, to help manage her own self and to relax after she's put the kids to bed at night or when she's got a moment's peace. That doesn't automatically mean that her cannabis use is a problem for her parenting. So it's really difficult for practitioners who don't work around alcohol and drugs all the time to get across the basic concept of the presence of substance use is not a risk factor. It is the context of substance use that produces risk, and often taking substance use away or requiring abstinence from particularly victim survivors is actually just adding to their problems. Women will have kind of strategies in place for managing the risk to their children because they're really well aware of it. And so it's understanding, is there anything I can do to help you to manage that risk better? And then when we can get you out of the highly stressful situation, then maybe we can talk about what your goals around your substance use might be. But at no point will we require total abstinence from someone. So it's that kind of a sitting in the messiness of it, I think, and accepting that that you might see things that you wish people weren't doing, but you can't choose not to do it for them. They have to choose that for themselves.
Add something to that as well. I think that really resonates as well with sort of the approach we have in the domestic family violence sector, in and around that we will include substance use and harm minimisation in terms of how we do safety planning. So we won't have an expectation or an idea that this substance use needs to end or change at all. Instead, we will say, how can we help and support your safety plan around that? And if we can then do that in combination with the harm minimization or together with the AOD sector, like that's where we can create these really beautiful integrated responses as well.
One of the exciting developments in Victoria is in the refuge sector, where traditionally women who are using substances or to a point that it may be disruptive to other residents are not allowed to enter, and that can be a risk factor for them. And so there's some joint training happening developed by Two Peaks in Victoria to really start talking about this. And I'm aware of at least one refuge where they're really thinking about how can they bring that harm minimisation approach into the refuge to enable a wider group of women to to get access to the refuge.
Margaret, do you know, is that training available only in Victoria, or is that something that people outside of Victoria can access?
They're 2 Victorian peaks. You'd probably have to talk to them, but I can we can share details so that you can follow that up if you like.
I guess just the bit I'd like to add to it is that the refuge we're talking about that's really looking at the harm minimisation strategy is saying, look, you can't just train frontline workers and hope that it's all going to change. This is a strategy from the top down and bottom up. So looking at the board and looking at all their policies, looking at all their guidelines, looking at their work with their partners who refer into that refuge. They're looking at from top to bottom and bottom up to say, actually, if we're going to make this shift across the domestic violence sector and particularly the refuge sector, let's not pretend that this is a simple add-on. It actually is about how do we deal with both the complexity at the frontline worker level as well as within organisations, so that it's not just a minor change, it is something where we need to support organisations and frontline workers.
We heard a provocation in the video that a Royal Commission of Inquiry or to establish an authorising environment to do intersectoral work between the AOD and DFE sectors could be a useful way of moving forward. Do you think that that type of approach would work in Queensland?
No.
Why? Tell us more.
Because we already know what we need to do. We've known for a while now. And actually, why would we waste more time building an authorising environment when in Queensland we've just had the Women's Safety and Justice Task Force that reported in 2023. So that is our authorising environment. And sure, it was run by the previous government and then there's the whole political bit. But the reality is that we can't afford to lose any more time. So we have structures that can help us do this work. In Queensland, we have the Mental Health Commission, we have the Human Rights Commission. I think this old school way of thinking that if we could just gather everyone's stories one more time and write another set of recommendations to Parliament, that magically a minister's going to go like, oh, actually, I think I understand what it is you're saying, because it's not the top-down piece that we need. We did a piece of work during the pandemic because we were a bit bored around what are all of the inquiries, strategies, government kind of pieces of work around alcohol and drugs over the last between 2010 and 2020. And there were 100 and something of these things, and almost none of them were health-driven. All of them were from corrections or from policing or from DV or from child safety. So it turns out everyone's more interested in alcohol and drug work than the health system is, which as somebody who works in the health system, I can attest to, because I'm always jumping up and down trying to get their attention, and they go what would you like now, Rebecca? And I tell them, and they give me a bit of money and I go away for a bit and then I pop up again. So mostly what they recommend is the things that we're talking about here today, right? It's about better collaboration, breaking down silos. Stop me if any of these start sounding familiar to you. New programs and pathways and vulnerable groups. Who are the vulnerable population groups this go round? And so you end up with reproduction of good stuff, no doubt, but actually the problem that we have in system reform isn't at the knowing what to do, it's in the how do we do it. And so I guess representing services that are experts in behaviour change, I think systems change is behaviour change on a mass scale, right? Because we want everyone in the system to behave slightly differently. So in a positive way, we would do that. We wouldn't do that via a commission of inquiry. We'd do that by breaking down some of the barriers that stop good work from happening. If my AOD workforce can get access to specialist DV social workers to just give them a bit of advice about cases as they see them, that improves the response. If our member organisations can offer people supervision that's specific to their interactions with people who are either experiencing or using violence, that improves outcomes. We saw that through the work we did. And also, our workforce already knows this is a thing they need to be focused on. Our workforce survey found about 80% of the 500 or so workers we surveyed see people experiencing violence in their work every week. And they see people using violence at least monthly. So this is not something that they're wait, what are you talking about now? Oh, I need to be educated about this thing, because they are living it already. It is where I struggle is at the bureaucratic level. So our capability building work was recommended by Justice but funded by Health. It took 4 years to get Health across the line with issuing a contract. Now that we've delivered the baseline work, then the struggle becomes, oh, well, there's no more money for that because the health system doesn't prioritise social services work. But if I went to the women's safety kind of project management team, they would say, well, you're a health service, go back to health and ask for that money. And we see that everywhere, right? So we know intersections exist. We have to shift the way the system responds to those intersections by freeing up people to be able to work together and sharing our knowledge so that you don't have to be experts in AOD and I don't need to be a DV expert, but I know you and you know me, and together we, our powers combined, we can solve all of the problems for people except for the big ones, the big structural ones that we need the system to do.
Does anyone else have any other reflections on the idea that we already have the authorisation, we already have the knowledge, it's the change and the action that we need to take?
I think when we did these interviews that are the basis of the PIPSI project, the themes were that really, yes, this is at the cutting edge of innovation and suddenly there's a lot of interest in this space and how to do it. And that's exciting to be at the cutting edge. And there's another group, Rebecca would have been part of this interview, going, yeah, we're so tired, we're exhausted by this issue. And so that we've been pushing on this, so that I wrote my first papers on this back in 2005. Says that I'm an old person. But anyway, and that was back in England where we ran the Stella project. And we thought that was AOD and domestic violence working together. We did this terrific handbook for the Greater London Authority. And there seemed to be a whole head of steam behind it. And then, guess what? It's not gone anywhere. It's gone somewhere, but incredibly slowly. It's glacial because we haven't got the economic drivers and the policy drivers which say you're allowed to do this work and here's the funding and the resource to do this work. So that with the siloing, we have a chasm and you're always hitting the chasm.
Yeah, our Mental Health Commission, and I don't mean to throw shade at them publicly, but I've already started, so I guess I have to now. Their approach to system reform is project work. So they will put out 18-month grants for $150,000 a go, and then they go, oh, you just have to know there's no recurrent funding. We can't, even if you find out this is the best thing we could ever do, there's no more money. And that's the problem we need to solve, I think.
I think the other thing I'm hearing from practitioners in a range of research projects is they're desperate to collaborate and they feel so nurtured by talking to people. And I'm going a little bit broader than substance use here, but the principle applies. But there's very little resourcing. There's no resourcing for that work of going and visiting another agency, seeing what they do, understanding what they can do and what they can't do and how you can work together. And then they've got their managers saying, who may not actually understand the issue as well because they've sent their practitioners to training and haven't done it themselves. But also having to say, but our core business is. So my current catch cry is, can we go beyond core business? And it's particularly in terms of working with children, but it's also anywhere where we're knocking on the walls of these silos and practitioners are just caught in it. And Beck, you're talking about the bureaucracies and managers are kind of caught in the middle and having to enforce them in a way. And to survive, a practitioner has to limit what they can do. We know a lot of practitioners who are bending over backwards to try and do everything. I mean, Paula, you can probably talk more about that. And it's not sustainable for them.
I'll just quickly add to that because I'm wondering, from what I'm hearing from everyone at this table, it doesn't sound to me like there is an authorising environment at that structural level to enable sustainability of this work. Whilst frontline practitioners know they should be collaborating better, they want to do this work as well and coordinate with people from outside different sectors. There are so many of these structural barriers that mean that they're not being well resourced enough or being supported enough to actually do this sort of work, which is what motivates a lot of practitioners to go into the field in the first place. So I guess my point there is, well, how can we dismantle some of these systemic barriers in place that's hindering either holistic or well-coordinated work to ensure that it's not only practitioners that are expected to change and evolve their practice with families, but also those who are on that bureaucratic level as well. How can we ensure that they're evolving their practices to try and rearrange funding structures in a way that's actually supportive of these organizations who are often placed with the responsibility of constantly innovating and applying for funding grants to better support the cohorts they work with.
I was just going to second what you said about our practitioners who are DV specialists, sexual violence specialists, child sexual abuse specialists, and absolutely right. They do sit in that space where if it's about client-centered approach, if it's about them looking at someone as a whole of person, you do enter a lot of the intersections such as AOD, mental health in general. And there is almost no end because you can keep working in that altogether. But I think, again, what we're doing here, if we're breaking down those silos, if we're breaking down those barriers, is that will just be that increased support for our practitioners so they can continue that work and it can be maintained as well. And yeah, you made a really good point there as well before. So yeah, really wanted to just speak to that aspect of it, that I can see how if we look at actually, we have these beautiful AOD practitioners, we have these really experienced domestic family violence practitioners. If we allow them that space, if we allow them that breath, if it is something that might be a little bit outside of their comfort zone, a little bit outside of their, there is someone else there that can take courage of that and can walk alongside them, which is we talk about our clients, our participants, our victim survivors, walking alongside them, and that would be a space where we can walk alongside each other as practitioners as well.
I think that one of the things that's been really unhelpful too, because it's not just that practitioners have been given an excuse to stay in their own lane, by this notion that because it's not causal, therefore it's not our business. And there's fear that if we take on in the domestic violence sector the issues of substance use, that in fact will dilute our messaging around gender-based violence. So that just to be really clear and reiterate again, the strongest data we have in the world internationally is that domestic violence is a gendered issue. Okay, so every prevalence survey, wherever you look, would say very clearly that that this is a gendered issue, and so we need to address the issues, particularly of male violence. But alongside that, and so this is at a different level, we're also saying that if you look at the issues around where substance use is used in relation to domestic violence, so as a tactic of violence and abuse, then the impact, the severity and the frequency of violence increases. Who's being murdered? You know, if you look at our fatality stats, if you look at the homicides, and a very good piece of work, 250 homicides, domestic homicides from 2010 to 2018, 60% involved the perpetrator being substance use affected. Now, that doesn't mean to say this guy's an addict. It doesn't mean to say that that's the cause at all. We're not saying that at all. We're saying how is it being used in this space to rationalise, to excuse, to make it possible for this murder to take place.
And in our part of the world, the opposite is true, right? So when we did this capability building work with the sector, there were some who were like, but that's not our specialty. Our specialty is behaviour change around substance use. And actually at the same, which is why the workforce survey was so important, right? So it was like saying to services, but your workforce is seeing this all of the time. So you might want to not get involved in it, but it's already here. And more than that, it actually is an issue that affects your workforce personally as well. So around 75% of the workforce sample knew someone or had a personal experience of being affected by someone else's violence, DV, and a surprising number were willing to tell us about knowing people who used violence in their personal life as well. So, I think this, and so the way through this for me is to talk about the social, cultural, structural determinants of health, right? Because these are, we say to the health system, if a person is experiencing family and domestic violence, then our intervention with them is only going to take them so far, because they're still going to be living with violence. So they're just going to have to find another way to cope with that. So, and the other part of this is, if we have men using violence in our services, then we risk being sort of turbocharging those men with therapy language to then take back out into the world and then use to say, well, I can't be better than this because my therapist told me that I have a trauma from my childhood that blah, blah, something's get out of jail free card. And so just being able to confront some of those myths with the sector, I think you get a bit of a sense that we need to head in a direction where it's a little bit more like social and emotional wellbeing services from our First Nations communities, where we're looking at the whole person, and we might not need to solve all of their issues, just the one they actually presented to us with, but the opportunity to educate or to open their eyes to what might be the real thing that's going on underneath is one that we are missing every day, and we should stop doing that as fast as possible.
And I think the way the words I've used to think about some of what you're saying, Beck, is about where you're attending to, a person, the harm they're doing to themselves, but you actually can't not attend to harm they're doing to others at the same time. You've got to keep that balance, don't you?
Yeah, absolutely. And residential services do this all the time. Like, the entry processes are you safe to be in our therapeutic community? And if your behaviour is not aligned with non-violence and collaboration, then you will be exited from services. So it's about who's being affected by the violence, and is it happening in front of my face? Because if they're doing that in a community, then they're doing that elsewhere as well. I think that's the thing that people miss. And I think it's the shift from incident-based kind of responses to noticing patterns of behaviour. And I think AOD services are really good at noticing patterns of behaviour. So I'm hopeful that if we can help them to just see this pattern, that then it will become normalised for them to respond to it, right? Because as quickly as you look away from something, you can also lean into it if you feel confident that you can help with that thing. So that's what gives me hope.
See, Therese, in the beginning you asked us, what does collusion look like? Well, collusion looks like actually only talking about the trauma to himself and not the trauma to others. And so you've got to hold both, and that's why we need to move from a trauma-informed model to a violence and trauma-informed model. And so there are now developments in this space around looking at trauma and violence-informed, not just trauma-informed. And we shouldn't use the word should I? That, in fact, it's more helpful in this space to be looking at violence and trauma-informed work, and this notion of not only the harm to self but the harm to others, to not have a collusive conversation. And too many of our conversations have necessarily been collusive.
Share examples that you've witnessed where practitioners are finding ways to meet the needs of the people that they work with and getting around the systemic barriers in their way.
When I reflect on me and my team, I think it kind of speaks a little bit to what I said before, is when we look at so a lot of the work that we do is risk assessment and then safety planning. And we work at the intersections of gendered violence, and we support victim survivors that have been referred by primary health providers like GPs and nurses. And so when we look at really getting around, and I don't know if I would necessarily use the word getting around barriers, but like I said before, we use a whole of person approach. So we look at what is it in the full life of this victim survivor, what's their experience, and what is it within their goals that will help us reduce the risk that they're under, and I want to use some language here, actually holding the person using violence accountable. So the violence that person's perpetrating. And that could look like anything. That could be a victim survivor themselves potentially using AOD to kind of just maintain their ability to continue to live through the coercive control and the verbal abuse that is happening in their relationship. And then we would look at, okay, what are some other things that we can support you with in the toolbox that you might not have access to as an individual, but that we as a system, as a representative of an organization with a system, might be able to help you with. Or it could even just be, if that is all of the only thing that in that particular circumstances works for that victim survivor, it might be us providing them with empowerment, providing them with support, support language, supportive actions, etc. And in regards to that as well, I think when we really talk about the intersections between gendered violence and AOD as well is, sorry, I think I've lost my train of thought there a little bit. Does anyone else have something to say? I'll come back to me. Did anyone else have something to say?
So I think when I think about getting around systematic barriers, the first thing that comes to my mind is collaborate. So really engaging in those relationship-based approaches with other stakeholders within the sector. I think about how just even at a local level, that has created so much impact for families. And again, my focus is on children. And so those little people having their voices heard, having their experiences understood through the lens of the non-offending parent, through their own lens, if they're able to speak to us and to speak to their experience. So impactful to be able to collaborate with other stakeholders. Mags just gave me in my ear a little think about the pattern-based approach, and it really is. So if we're able to hear from the victim survivors, from the children, if we're able to understand how the PUV's use of violence, use of tactics of control, coercion, use of substances, etc. If we can understand that pattern and we can articulate that, then that goes such a long way to being able to work within the system and work with the system to create safety for those children and for families that are impacted by family violence and substance use coercion. Did I get it right, Max?
Sounds good, Mon. But I'd add documentation that
Thank you, yes.
so many practitioners know this, and they have all this wisdom and all this knowledge in their heads. But when you write it down, and you write it down for child protection or you write it down for the courts, it can make a dramatic difference to actually join the dots and show a professional in a decision-making role what's happening and what the impacts are. Can actually, as I say, make dramatic difference.
And it can bring more people to the party,
Yeah,
can't
go
it?
on.
Because if we have, thank you. But if we have it in black and white and we can present that, we may be able to bring other people on board. So thinking about that example that I provided earlier in the piece, that's exactly what's been able to happen. We've been able to bring key stakeholders on board, including the child protection system, including a specialist family violence provider that works with men in the case management area, bringing them on board to collaborate around how best now to work with this particular person using violence in order to create change and create safety for his children and for their mother as well. So without using that pattern-based approach, without having those things really clearly documented, it would have been difficult to then bring those people or those stakeholders on board.
Just remembered the other thing that I was going to add to that as well. So we work, as I said, in an intersection with sort of primary health. And I think a key factor to working in that integrated response and for our practitioners to feel like they're not just doing that individual advocacy, but also that systemic advocacy, is that we're able to provide resources, we're able to provide direct training, we're able to actually upskill the sector, and therefore feeling not only is it that they are referring into us and going, here's a victim survivor, can you support them? But it's us going, actually, this is the support we can provide, but with their consent, this is how you, in kind of a different space, can really make a difference. And so we feed that information back, like as I said, with consent. And then the primary health practitioners are part of that conversation. They're part of that idea. And that's how we have achieved some of our really, really, really good results as well.
I guess there's a number of different spaces where I think that we can really address some of the issues around how do you collaborate effectively so that, you know, you're not necessarily looking at more resources or huge numbers of resources. I mean, we are in Queensland where they've had a huge rollout of the Safe and Together model. And, you know, starting with a shared language, like one of the things that brought Odyssey House and Kids First together was the fact that all their practitioners and managers were trained on Safe and Together. So they had a shared language around the dynamic of how you understand domestic and family violence where children are involved. And there's something about that core that's very, very helpful and cuts through and saves an awful lot of time and saves an awful lot of advocacy because you're there. I guess a second thing I think where there's already high levels of collaboration around high risk, and that's where you've got high risk panels. So that in Victoria it's the RAMPs, in New South Wales it's the SAMs, in Queensland it's the
HRT.
Yes. So those are collaborative forums where if we had all those workers trained up well around substance use coercion, you'd have everybody doing their job in this space with both a shared language and a shared plan.
Just on HRTs, none of the services that we worked with, and there were 40-something of them, were directly connected to high-risk teams. Even in the public system, the high-risk team contact was usually someone from the social work department of the hospital. And so the mental health and AOD services job was to like tell that social worker that I think this person is high risk, and then and then what happened? And they're like, I don't know, because no one ever circled back to me. And then in the non-government sector, there wasn't a single AOD service that even knew that HRTs were in their region, let alone how they would refer to those. So there's a problem in the way that up here the system conceptualises itself. So it tends to be government agencies talking to government agencies and then going like, wait, there's an NGO sector? But wait, what do they do? And it's too many people. We couldn't possibly include them in our thing. But that's kind of the next step, I think. And that's what I see that Victoria does much better than Queensland. And probably that's because an eon ago, a lot of service delivery was pushed out to the NGO sector, whereas here they've held it back in public agencies.
I think it's not just Victoria. I mean, I think the government sector needs to recognise how nimble the NGO sector can be. And often they've got the new and innovative ideas. But I agree, we've seen it in a number of states, that there's a kind of communication divide.
Yeah.
Talking of systems change.
But really, the projects we've done with the Aboriginal sector, you know, they've been doing a lot of this work on how you bring a whole of family lens where you've got domestic violence, where you've got substance use, where you've got mental health, where you've got poverty. And so bringing some of that learning into this space, I think, is very helpful in terms of the cross-fertilisation of ideas without wanting to sort of steal intellectual property. But it is about, you know, an awful lot of Aboriginal people coming into the mainstream sector as well as vice versa. So I think that there's learnings there that we could very helpfully understand and would take on the other issues of colonial trauma as well as being quite central and not marginalised in this space.
In terms of learning, where would you start to increase your knowledge?
There's not a lot of good options. out there. No. You could probably start with something like AOD first aid, but even so, here's an idea. Contact your local drug user organisation. Here in Queensland, that's Quiver, and ask them to offer your staff an introduction to alcohol and other drugs training session, and maybe on the DV side the same, but in reverse.
For the DV sector, the first thing that came to mind, and obviously I understand we're all really time poor, but I do like going back to the foundation. So if you're looking at it from a national perspective, that would be the National Plan to End Violence Against Women and Children. And then it's a Women's Task Force and lots of Hear Her Voice, lots of other documents, really on a foundational level. If you're looking for a little bit more about the kind of risk framework, like we have the CRAS, which is the Queensland recognised one, and there is actually specific training that you can search up. I don't have the exact website, but if you Google CRAS training, there is some really good resources that will give you some of that foundational knowledge of like what is risk assessment, how can you support your victim survivor with their safety planning.
If the question's coming from a single practitioner, go and have a coffee with a worker from the local AOD agency. The place-based stuff is actually, it's quite important to know all your local agencies set up a community of practice to discuss a case. And it's amazing when you start discussing a case from the different points of view, some of that learning happens organically as well. Just another idea.
Sorry, it was just a note about the coercive, which is a great document. It has exactly one question on substance use, and it uses the archaic term that should really be reserved only for what people do to each other. So just to be clear, you can't abuse substances. They don't have feelings.
Oh, come on.
Well, I just want to say that attending forums like this is most likely a good place to start to even identify that this might be a gap in your knowledge. But also from what I've seen of practitioners on the ground, when they've identified a gap in their knowledge and they're interested in learning more about other issues or other sectors, yes, place-based networking and collaboration is definitely the go-to. But also I've seen practitioners overcome these sectorial silos by forming their own communities of practice, even within their state or even nationally. So really that's about mobilising the current knowledge and communities we have in place to ensure that there's active knowledge exchange and social learning as well.
When we talk about substance use coercion, aren't we ignoring victim survivor agency and choice to use alcohol and other drugs?
Sometimes. Yeah, women use drugs. There's no issue with women using drugs. It's an equal opportunity sport these days. Maybe it's the first place we hit equality. I don't know. Haven't really thought about it. So I think there's a key difference here though, which is and it actually will be revealed through your engagement. So if you are looking at working with a victim survivor who uses drugs, who happens to also be in a coercive controlling relationship, it's not an automatic thing that the substance use is part of the coercive control. It might just be incidental. It may be, in fact, how they met in the first instance, that they were both people from the same kind of drug using community. So yeah, it's really important to remember that it's not always part of the equation, but the victim survivor you're working with will be able to tell you whether it's part of the pattern of behaviour or not. And that should be, I guess, where you start.
I was just about to echo that as well. Sometimes, which is why substance use coercion is only one subset of explanations when we're talking about the intersection of drug and alcohol and family violence. It doesn't apply to everyone, and we truly do have to be led by victim survivors, and whether they're reporting that their agency and decision-making around their substance use and recovery is being undermined by another. So the example that I sometimes give out is thinking through, a woman might be choosing to use substances, and that's a part of their autonomous decision-making. There's nothing wrong with that. However, if she returns home and a family member leverages that to undermine them, to control them, to excuse their violence against them, then I think we really need to unpack what sort of coercive controlling practices are happening in that dynamic.
I guess one of the issues is about how it gets weaponised, so that it's pretty easy, as Van said, for where women are using substances, if there's coercive control, it's pretty quick for it to be weaponised, you know, ringing the police, ringing child protection, etc., or threatening to do those things. So that it's very easy for it to become weaponised. And I think part of the practice is exploring that process and whether her help seeking has been closed down. Because that's the whole issue, is how can we act as a sector or sectors without closing down her help seeking? One of the most problematic areas is the fact that we're going for harm minimisation in this area, whereas some of the agencies, and particularly child protection, but also some refuges, it's abstinence. And so I think there's got to be some major shifts, you know, around, you know, taking blood samples, et cetera, to say it's got to be abstinence, whereas in fact we've got to explore what does harm minimisation look like for this particular man, woman, or for the children involved.
What service can work with the PUV to address substance misuse? For example, a grandmother whose 2 sons become violent if she doesn't give funds for drugs. Although there are orders, they are not mandated to attend behaviour change programs, etc.
Sorry, I'll start with a technical question. Is that substance use coercion, or is that just financial abuse? Because what they want to do with the money is buy substances, but it doesn't seem, you know, I don't have an easy answer for that, because, you know, our programs in the AOD space really only work when people choose them for themselves. There are some examples of mandated kind of treatment that, you know, the researchers will tell you that it has at least as good a kind of outcome, because some people have a little epiphany once you get them into treatment. It happens occasionally. But I don't know that in that instance, if you took away the substances, that the financial abuse would resolve. So maybe focus on the financial abuse in the first instance.
People who are using tactics of violence and control, getting them into programs where they want to be and engaging, we know is a really big challenge. This is a half-formed thought, and somebody else might be able to pick this up more eloquently, but I'm thinking about you can give people the choice to engage with their behaviours and change them, or you can go through an accountability loop. And what does that look like? I'm not quite sure what it looks like in that case example, but isn't that the alternative?
I also wonder, we've spoken a bit about breaking down silos, thinking about staying in your lane, those sorts of things. And when the question is whose responsibility is it to work with the person using violence, is it everyone's responsibility? I guess I pose that question in terms of, if no one has a conversation with the person using violence, then are we in effect colluding with his choice to use violence? Should I just leave that out there? I'm not sure, Kathy.
Nice one, Monique. Nice one. Yeah. No, but I think it's absolutely right. We are looking at no wrong door. And so that does mean for both victim survivors and for the person using violence. And if you're using the Safe and Together model, you know, it is always about pivot to the person using violence as the starting point. And so it is about how do we engage, and is there any potential to engage in that space safely or not? But I do think that Beck's right. This is about financial coercion. But I guess it's where it's so helpful to talk about substance use coercion. It's just an aspect of coercive control. And I think that this is where we change from saying, is it causal, is it co-occurring, to saying, look, this is part of the fabric of coercive control, and it's one of many tactics that's being used in this space.
Give a piece of advice or share a piece of wisdom about how to navigate this very complex issue of substance use coercion and working collaboratively across these spaces.
Okay, we're running out of time. I'll keep it short and simple. We don't expect practitioners to do this on their own, right? We ideally the idea of substance use coercion is to unpack really complex family dynamics that are already occurring in frontline practice to support better practices in response. So really, I cannot emphasize enough that there really should be support networks in place when a practitioner is interested in evolving their practice, both from a managerial level, organizational level, and a systems level as well. So that's really my final conclusion.
I guess it's both working at a frontline level, which is saying, let's explore well the tactics of violence and abuse and see this as part of coercive control. Therefore, it's core business to the domestic violence sector. This isn't something that is going, oh, that belongs out there because it's not causal. Coercive control is core business for particularly the domestic violence sector, but also we're looking to support and help from the drug and alcohol sector to really also take on this issue, because this is where people are coming through the door as well.
I think we're all saying versions of the same thing, aren't we? I'm just trying to think what I was going to say. It was about collaboration, about, again, not trying to do it on your own, ensuring trying to get your manager to support you, as Van pointed out, but understanding that, you know, we all, as Mon said, everybody has some responsibility, and that means it's shared. That no practitioner can actually solve a problem on their own. It's the network of services that can help in these situations. So use it.
So many thoughts. And I was just thinking in all of this, there's a couple of things. Maintain your curiosity. So thinking about the, what's underlying these issues, what's underlying for the PUV, what's underlying for the victim survivor, what is underlying for yourself as well. So really checking your biases when you're doing this work. So that, and at the same time, be kind to yourself, because like was said just before, no one should expect practitioners to be carrying this all on their own. There should be a network around families and also around practitioners to support them to do this work. So those would be my two key takeaways.
For those working in the AOD space, particularly with men who use violence, my advice would be to get really good at making sure you notice when someone's trying to dehumanize another person in your sessions. So make sure every person in his life has a name. You know it. You use it every single time you're talking about those people. And that there's a lot of the skills around behaviour change and motivational interviewing that are easily transferable, so long as you understand the gender aspect of this. You can't come into this work without acknowledging the gender, the really strong gender component, which I think challenges some of our practitioners. But once you get the knack for it, this nests really beautifully in alcohol and other drugs practice. So, that's my advice.
For me, I would say in the domestic family violence space, and I think having worked alongside you for a while, you do this beautifully, but it's about centering the voice of your victim survivor. Being in a bit of like a maybe contentious, if that's the right word, industry, there's a lot of these external factors that really come to mind where it's like, we need to do this, we need to do that, we need to have this, all of these things need to be in place for your protection. But as long as we just listen, I know that we can hear actually what is it that our participant themselves, our victim survivor, actually wants and needs and feels will keep them safe, or what is it they want in their life, and that could be, it could be staying with a person using violence, it could be leaving, it be continuing using AOD, it could be stopping to use it as well. But I think that voice is so incredibly strong when we have these beautiful relationships, and I think that's really what we want to keep centering in our work.
That was excellent. Some really brilliant gems from our panel there. I would like to thank everyone for joining us today. We have reached the end of our session, and I'd really like to thank all of our presenters for their insights, their reflections, and all of you for your active participation and thoughtful questions. Today's conversation has reinforced how critical it is to name substance use coercion, to build shared understanding across sectors, and to support practitioners with clear, practical approaches to this work, even when resources are stretched. And your engagement today shows how committed this sector is to strengthening our responses. A recording of this webinar will be available on the WorkUP website as soon as possible, and for anyone who's registered, we will notify you as soon as it is available. We encourage you to share it widely with your networks. If you have any questions or comments or suggestions for future Spark webinars, please don't hesitate to contact me at teresa.kellett@anrose.org.au. That'll be dropped in the chat. I'm Teresa Kellett on behalf of WorkUP. Thank you.